Hi everyone, I'm Jesse Cordier. I'm one of the Peds Radiology attendings here at UCSF Benioff Children's Hospital, and this is a short review intended for just a brief overview of some of the basics on neonatal lung disease and neonatal chest radiographs in particular. The target audience is for specifically for first-year radiology residents rotating through the service for the first time, but it's also helpful as a general review for others who are maybe studying for their examinations. There's a lot of really useful information in this review article where this article discusses not only congenital lung abnormalities like chest x-ray findings that we're going to be discussing, but also describes some of the other congenital lung abnormalities in detail. So I think this is a great review article. Just wanted to recommend this. The overall objectives for this short talk are really to focus on what I think are the classic patterns and the classic appearances of some of your most commonly encountered neonatal lung pathology in premature and term infants. We're going to talk also about some common treatment-related complications of neonatal lung disease. And we're going to finish by talking about some important differentiating factors between the major processes. I think what you'll find is that there is a fair amount of overlap between any of these major entities, but what I want to emphasize is just really being able to know some of the classic presentations, and you'll see when you rotate with us that, again, there is a lot of overlap and there's some variation between interpreters. But I think it's important to have some familiarity with the bread and butter classic presentation. So we're going to talk about surfactant deficiency disorder, retained fetal lung fluid, meconium aspiration, and neonatal pneumonia. Those are the biggies that we're going to be talking about today. So again, the lung findings by themselves really aren't very specific. This is where we're going to use some other information from associated findings like presence of effusion, air leaks, or expanded lung volume, and also pairing that with some clinical findings as well. Integrating all of these is really essential for accurate diagnosis of neonatal lung disease. Again, our lung findings by themselves are pretty nonspecific. And before we get started, I just wanted you to see an example of what a normal is, normal term infant. As we can see, we have a pretty nice thymic shadow right along here, and it has this undulating appearance, undulating margin as it goes along the rib surfaces. Again, this is what a normal, healthy infant looks like. The cardiothoracic ratio, that is, for infants is actually greater than around 60 to 65, and that's persists up to about 6 months or so. So again, the heart's going to look bigger than you might expect if you were comparing that to an adult. A little bit more of an up-close view. What we should see are these tubular opacities on a lucent background, a nice black background. So sharp, well-defined vessels on a black background. Look up a little bit closer, and here's what we're looking at. And again, this is what we should be seeing. We should be able to discriminate those vessels nicely. So let's talk a little bit about premature infants. Again, the definition is less than 37 weeks. There's a fair number, and it's actually increasing the number of premature deliveries per year. Again, the lung disease is the most common problem with these kids. Surfactant deficiency disorder goes by a few other names, respiratory distress or Highland membrane disease. Again, about 1% of all live births. And what we'll see on the radiographic appearance are very diffuse, symmetric, granular opacities bilaterally. The lung volumes will, in general, be normal to usually low. And this is a very classic appearance for surfactant deficiency on this radiograph. Again, generally the kids are going to be less than 34 weeks to have this appearance. And again, it drops once you get past 35 weeks. That's kind of the cutoff. Again, infants of diabetic mothers, twin pregnancies, and males more common than females are susceptible to this. So what is the purpose of surfactant? Surfactant is a substance that helps to reduce the surface tension. much in the same way as when you're blowing bubbles using soap bubbles. The soap helps to reduce the surface tension and allows this to stay open. Without that material, this surface tension is much higher, and this leads to alveolar collapse. So again, the gaseous exchange is impaired because of this collapse. You don't have these nice, well-opened alveoli. And again, you can lead later on to this capillary permeability and higher membrane formation. And again, usually this happens around 4 to 6 hours, symptoms, onset of. Again, clinically, they're going to look something like this illustration here with retractions, nasal flaring, cyanosis, expiratory grunting. This is a classic clinical appearance for these kids. And as I mentioned, typically the lung volumes are small. They'll have these diffuse bilateral granular opacities. You may have loss of the vascular definition. Typically, they do not have any pleural effusion. Again, here's just another example of up close what Highland membrane disease is. Remember our earlier one where we could easily pick out the normal vessels on the black background. Here it's starting to become more obscured, but again, it's a very symmetric, diffuse, widespread appearance of these opacities. Again, an up-close look just to show you what we mean when we're talking about granular opacities. So this is treated with the delivery of surfactant via the via the endotracheal tube. Here's an image on the left side with pre-treatment, and the image on the right with 6 hours post-treatment, status post 1 dose of surfactant. Usually a very symmetric response. However, sometimes the way that the surfactant is delivered can go asymmetrically to the lungs, and you can get a very coarse look. This is a kid about 2 days out, status post surfactant, and if you didn't have the clinical history, you might think some other entities like a neonatal pneumonia or meconium aspiration. But just to know that, again, this is where integrating that clinical history is very important. There are a few other things that can happen after the administration of surfactant. Here we have a kid who is about 24 hours out from getting surfactant and is now showing a lot of these widespread consolidative opacities with air bronchograms. And this is one of the complications that can arise from that, and that is pulmonary hemorrhage. So again, with a history of hemoptysis, and we see these widespread opacities, again, pulmonary hemorrhage is something that we could consider and is a known complication of surfactant treatment. There are also some complications that are related to respiratory airways or air leaks. Here's an example of pulmonary interstitial emphysema. We'll talk about that a little bit more in a moment. But what we're seeing are branching bubbly lucencies that are coming centrally and expanding outward. And these branching bubbly lucencies, that's what we're looking at. And again, just another up-close look at pulmonary interstitial. And again, what that is, again, these are just these bubbly lucencies that are coming out. This is a pathologic specimen just to try to illustrate that a little bit better. We can see air completely lining around the pericardial sac here. Along the same leaks, there's pneumomediastinum. This is elevation of the mediastinal leaves. This is known as the angel wing pattern. You can see that typically what the thymus will do will be to sit right along this area, and this is elevated and pushed out, like out that way, by the air in the mediastinum. So this is referred to as an angel wing sign in pneumomediastinum. Just another example of another form of pneumomediastinum. You don't always have to have it bilaterally. You can have just one side, as we have in this case. Long-term sequelae of surfactant deficiency and complications, the main one is bronchopulmonary dysplasia. The newer term for this that is generally used in the literature is chronic lung disease, just a more generalized term, where we have about 4 weeks out. As early as 10 days, you can start seeing the manifestations of this, but typically it's seen about a month out or more. where you'll see these very coarse opacities instead of the fine granularity that we saw earlier, much coarser look. And then we'll talk about that more in a moment. And then one other complication is a patent ductus arteriosus. When you have very high resistance in the pulmonary bed, the ductus arteriosus, which is normally closed, can reopen and cause widespread pulmonary edema, as we have in this particular case. So this is an example of widespread pulmonary edema, very symmetric look in a kid who has a background of surfactant deficiency and has opened up his ductus arteriosus. Again, just a few more words about pulmonary interstitial emphysema. Again, these are these cystic or tubular lucencies. You can have either a focal form or diffuse form. It can be on one side or both sides. The main thing is that this is related to alveolar rupture, and it can lead to things like pneumothoraces, as we have in this example here. And so this is something that when we alert the clinicians to, they do make clinical changes based on this. They will go to a different type of ventilation setting in these kids, often going to a high frequency ventilation. Usually what the setting that we see this in is a kid who is on a ventilator and has a background of surfactant deficiency, and then they have chest x-ray that may look like standard surfactant deficiency RDS pattern, and then they all of a sudden have these branching lucencies, and this is what we see in PIE, or pulmonary interstitial emphysema. In the more severe cases, we can see other complications of air leak, like the large pneumothorax we see here, or even mediastinal shift. Just a few more words about bronchopulmonary dysplasia. The original definition had some clinical signs as well with it. Clinical signs of respiratory compromise and some vent changes, and also some characteristic abnormalities. Again, that definition has been changed a little bit. What we, from our imaging standpoint, use are just history of surfactant deficiency disorder in a kid who's typically been on ventilation and now starts to have these coarse interstitial opacities. And again, there is a new definition for this. It's not as common to see the more severe cases that we have seen in the past. This is the actual definition. The newer criteria set forth for this. They group this into a mild, moderate, or severe. Just in practicality, this is not something that we put in our dictations or our reports. Just being able to recognize with a history of surfactant deficiency or history of prematurity, being on the ventilator for a long time, and now starting to see some coarse opacities, that's really as far as we take it in clinical practice. And what will we see? Disordered lung aeration, heterogeneous pattern of opacities, some cystic lucencies potentially, which end up being pneumatoceles, and some regional air trapping. They actually do slowly get better, and typically they're asymptomatic by 2 years, with the x-rays normalizing years. That being said, the pulmonary function tests usually are abnormal for a longer period of time. And those kids who have refractory pulmonary hypertension in general have a worse prognosis over long term, and may end up needing a lung transplant. A quick mention about retained fetal lung fluid, also known as transient tachypnea of the newborn. It's not as common. This mechanism of the lung fluid being squeezed out during delivery, there's some folks that have put that mechanism into question, that may not actually be the reason behind this. That being said, what we do see typically are streaky opacities, usually not very, the lung volumes are typically either normal at best or maybe slightly expanded, but this can be challenging to differentiate from some other entities. Typically, however, this will go away within 48 hours, 72 hours at most. Again, C-section, heavy maternal sedation, these are all sort of classic reasons why you can get retained fetal lung fluid. And you may see some fluid within the fissure, may see some pleural effusions. Again, usually 24 to 48 hours is when you see it. 72, it should be almost completely resolved. Just to mention a little bit about meconium aspiration. This is a disease of term, usually, or post-mature infants. Actually, there are many pregnancies that have meconium-stained fluid without the actual aspiration, but it's something for them to be aware of and look for in chest radiography. Again, can be really toxic. The child aspirates the meconium, it goes into the airway, and it causes a chemical pneumonitis in the lungs. And actually up to about 30 to 50% require some formulation. So what we'll see are, by imaging wise, these coarse, widespread opacities bilaterally. Again, they don't have the symmetry that we saw with the surfactant deficiency cases. A little bit different, very coarse. We don't see the fine granularity that we saw in the other cases. And then after we have these opacities, these can lead to things like air trapping, pneumothorax, pneumomediastinum. That can all be secondary to the process of meconium aspiration. Typically, our lung volumes will be increased in this particular case. Again, patchy or confluent coarse opacities. We're going to look for things like pneumothoraces, and remember, in these infants that are lying supine, so we're looking for pneumothoraces more typically in the anterior aspect and the lung bases. That's where it's usually going to hide. It's rare to have any pleural effusion in these cases. These kids will be put on treatment with antibiotics and surfactant. They will usually require some mechanical ventilation, as we mentioned, as well as some other clinical interventions. But actually, up to 94% have an overall, actually a better survival rate than you might think. So again, burn this pattern into your brain. This is a classic look for meconium aspiration: coarse, widespread opacities, increased lung volumes, no real effusion. When we see it, we're going to be on the lookout for pneumothorax or pneumomediastinum, some of those air leak complications. Mentioning this one as well, this is neonatal pneumonia. Again, a small minority of term infants, but can either be acquired or acquired after birth, or in utero, that is. This can be tough radiographically and clinically. Neonatal pneumonia, it's not like a pneumonia we think of in an adult, a community-acquired pneumonia where we have a dense consolidation in one of the lobes. Typically, it's going to look a little here, where we may have either fine granular opacities or more asymmetric coarse opacities in these cases. So it's going to look different than what we would expect to see in a few tricks or tips we can potentially use to look for this are pleural effusion. So if we see any blunting of our causal angles, this can be one hint that we're looking potentially in a neonatal pneumonia case. Again, just a few examples here to show you the different ways that this can present. Ascending infection during delivery or postnatal infection, these are all methods that the infant can, or the neonate can acquire neonatal pneumonia. There are a few things that put them at a higher risk. That is premature rupture of membranes that are ruptured for more than 18 hours, maternal fever, or foul-smelling amniotic fluid. All of those things are risk factors for neonatal pneumonia. Here, just another example of one of the varied presentations of neonatal pneumonia, where we have asymmetric coarse opacities, possibly some small effusions. The lung volumes are either increased or I would probably call these actually increased. So again, a very variable presentation for neonatal pneumonia. We mentioned a few different things like infection, maternal UTIs, or another thing that can put the child at risk, or some other type of known organism with transplacental potential. Again, as we mentioned, a large number of these will have pleural effusions, but if you don't have it, we can't really, that isn't something that can dissuade us from calling neonatal pneumonia. This often will require follow-up or clinical correlation. The one thing to be aware of, though, is the setting where we have a term infant, where we have a pattern that looks like it would be otherwise thought of as a surfactant deficiency. That is, the diffuse bilateral granular opacities, but the child is a term infant, so that doesn't fit, and that often is a specific type of pneumonia. GBS pneumonia can be a mimic for that. So something to be aware of. If you see what looks like a surfactant deficiency or RDS, but it's in a term kid, start thinking about GBS pneumonia. So just in summary of some of these things, we have to concede the lung findings by themselves are fairly nonspecific, but we can look for some clues like the associated findings, and with some clinical history we can try to steer at least towards a diagnosis. So if we see hyperinflation, what are things we can think of? Probably the biggest one is meconium aspiration, but transient tachypnea in the newborn and neonatal pneumonia are other things that can have this appearance. Here's an example of an E. coli neonatal pneumonia with hyperinflation. Just note that we have, again, coarse bilateral opacities, flattening of the diaphragms. We don't see the effusions, but this tells us that we should keep meconium aspiration on our differential, but also neonatal pneumonia can have a similar appearance as we've shown you in this example. This is part of the reason why the children are treated with antibiotics as well, because these can be clinically challenging to distinguish. Air leak. Typically when we see air leak, we're going to think about meconium aspiration. So if we see the coarse asymmetric opacities and some signs of air leak, as we see our thymus has been displaced here and is being lifted and elevated, this is a sign of pneumomediastinum, as we mentioned, an angel wing sign, and this is a sign that is usually typically associated with meconium aspiration. Normal aeration can be seen usually with neonatal pneumonia. Patchy confluent opacities, either pneumonia or meconium aspiration. Fisural fluid, typically either pneumonia or transient tachypnea of the newborn. So we have a few different things that can be seen with each one of these entities. Meconium aspiration, just a review of that. Confluent opacities, asymmetric and patchy. Lung volumes are usually increased. Effusions are usually rare. And if we see air leak, that can help us steer it in their direction. Neonatal pneumonia can either be reticular or confluent. Usually they'll have either normal or increased aeration, and this is where presence of those effusions, if we see them, can be really helpful to make us lean toward this diagnosis. Transient tachypnea of the newborn, reticular opacities, they're usually not quite as coarse as our opacities we've seen in pneumonia or in meconium aspiration. They may have fisural fluid, but this is where a follow-up is going to really come into play, usually resolving within 24-48 hours and should be resolved definitely by 72 hours. And to distinguish all that from surfactant deficiency, where the lung volumes will typically be low, where our opacities are going to be more of a diffuse granular appearance. Again, we should not have any effusions in uncomplicated disease. So if we see effusion, we start to wonder about possibly some superimposed infection or another process. All right, so that really sort of summarizes the major findings for what I think are probably the most common types of neonatal lung disease that you'll encounter on our rotation. And again, just a brief review of all of these, and I hope you found this useful. Thank you very much.